So thank you so much. I'll be talking on therapeutic targets for anti-VEGF agents, molecular insights, and clinical translation. So we know that in the current market, we have a lot of molecules which are being developed, and these molecules have multiple targets, and therefore more anti-VEGFs are being produced right now, and therefore it creates more confusions in the clinical practice. So when you have an anti-VEGF agent, it requires three levels of assessments to be done. One is at the level of efficacy, whether that anti-VEGF molecule is efficacious or not. Second is the durability of the drug, and third is the safety aspect to that anti-VEGF molecule. Let's talk about the anti-VEGF efficacy itself. And we know that in most of the retinal and the choroidal vascular diseases, it is the increase in the VEGF and the placental-derived growth factor because of the secondary hypoxia, which causes the VEGF receptors or the VEGF isoforms, VEGF and the PIGF levels to go up, which causes the secondary inflammation, neovascularization, and vascular leakage and edema. So basically, aflibercept, it has a multiple target approach where it acts at the VEGF receptor 1 domain and the VEGF receptor 2 domain, therefore blocks the VEGF receptor, VEGF isoforms A, and the placental-derived growth factor, and therefore it is useful in reducing as a significant anti-VEGF level. In addition, it has got action against the VEGF B as well as the galectin-1 molecule as well. And therefore, VEGF aflibercept has been considered as the standard of care outcomes to different multiple targeted approaches. Now, what's important to understand is, do you have any additional targets which needs to be considered beyond the VEGF receptor so as to increase your efficacy outcomes? And this is an important question which needs to be raised. And therefore, we have newer molecules coming up with smaller size, with high molar dosing, with the brolucizumab 6 milligram, molecules which have additional pathways of action where they are acting against the Ang2 levels with the faricimab and the nesvacumab, and then the surgical implantation of the ranibizumab molecule as well. So let's understand in detail what's the role of Ang2 in the vascular permeability and angiogenesis in neovascular AMD and DME and DR. And you would realize that it is the Ang1 which is a protective agent. It binds to the Tie2 receptors, and therefore it reduces or stabilizes the vessel wall and prevents the prevents the increase in the vascular permeability and therefore the leakage and the edema. Whereas the Ang2, which gets upregulated because of the increased VEGF receptors, it gets connected to the Tie2 molecule and therefore destabilizes the vessel wall and causes more leakage and therefore edema and angiogenesis. So this is a very important slide which tells you that it is the low VEGF levels which promotes the Ang1 get connected with the Tie2 receptors, and it is the high VEGF levels which is responsible for the upregulation of the Ang2 and therefore blocking of the Tie2 receptors, which is responsible for the pro-angiogenic and the and the inflammatory cytokine action. So faricimab, we know that it's a bispecific antibody which works against two molecules, that is the VEGF agent, which is the VEGF agent which is a part of the ranibizumab arm, and the second is the Ang2 action as well. And it also has a modified Fc fragment, which is very important because it reduces the risk of systemic exposure and reduces the inflammatory potential as well to any of these anti-VEGF agents. But does Ang2 inhibition contribute to better visual and anatomical outcomes? And this is where the clinical trials will actually help us in understanding. So this is a trial which was performed by Bayer and Regeneron, where they actually looked at the binding affinity of faricimab to the Tie2 receptors and nesvacumab to the Tie2 receptors, and they found that faricimab actually had a weaker binding for the Ang2 compared to nesvacumab. Now, when you look at the Ruby and the Onyx studies, which actually compared the role of nesvacumab in combination with aflibercept, and you would see that whether it is adding nesvacumab, which is an Ang2 receptor inhibitor, the visual acuity outcomes did not change much in comparison to the aflibercept monotherapy group alone. Even the Avenue study, which compares between the faricimab and ranibizumab in neovascular AMD, did not show a significant difference in the visual acuity gains over a period of 36 weeks in patients who were treated with faricimab with the 1.5 milligram dosing, 6 milligram dosing, or even a 6 milligram monthly dosing schedules. Now, the most important study, or the most commonly spoken about study, is the Tenaya and the Lucerne study, which compares the faricimab against aflibercept 2 milligram. And this additional blocking of the Ang2 agent with the faricimab did not give a superior visual acuity or an anatomical benefit over aflibercept. And this is something which you can see that over a period of 112 weeks, the visual acuity gains were almost comparable with faricimab faricimab and aflibercept, both in the TENAYA and the LUCENT studies. So the first clinical implication which I want to tell is that the low VEGF levels can be achieved by just suppressing VEGF, and you probably don't need an Ang2 blockade to be seen. Now let's look at the durability, and you know that there are three important things which increase the durability of the drug. One is increasing the molecular size, second is the binding affinity, and third is the molar dosing. And these graphs very clearly say that when you increase the molecular size, the binding affinity, and the molar concentration, and therefore the VEGF suppression time is increased in these cases, and therefore the durability of the drug increases. So you have the PULSAR 8 milligram study which spoke about the neovascular AMD, where it compares the 2 milligram every 8 weeks, the 8 milligram every 12 weeks versus the 8 milligram every 16 weeks. And you see the proportion of the patients who have got extended beyond the 12 weekly interval, which is around 62 to 65%. Even in the PHOTON study, you have a significant amount of patients, 91% of the patients who are able to achieve a 12 weekly treatment-free interval, and an 89% of patients having a Q16 treatment-free interval, which is much lesser with the brolucizumab group and even with the ALTER study group. The TENAYA study, which also talks about the 16-week interval, is only about 45.7% to 44.9% in the TENAYA and the LUCENT studies. And therefore, the second implication which I want to say is that the aflibercept definitely has got an increased durability in comparison to faricimab 6 milligram. Let's talk about the safety, and you know that the immunogenicity is related to the high monoclonal antibody levels, the high disease state, and the presence of pre-existing inflammation. And sometimes the modification in the FC fragment provides better protection against inflammation. Just to summarize, the VEGF is the main pathway in the management of retinal and choroidal vascular diseases. Ang2 promotes VEGF destabilization and increased leakage and angiogenesis. High VEGF upregulates the VEGF Ang2 levels. High binding, high molecular weight, and high molar drug concentration increases the durability. At the same time, it raises safety concerns, and safety of aflibercept in PHOTON and the PULSAR study is comparable to that of aflibercept 2 milligram. Thank you so much.
Thank you, Dr. Ramesh. I just want to ask, what is your first-hand experience between faricimab and aflibercept in functional and structural outcome?
So recently only we have started using faricimab. So we have only 2 patients who have got the 1-month follow-up visits, and we have seen a good improvement, which is almost as comparable what you get with aflibercept as well. Both the drying effect and the anatomical and the visual acuity gain is also quite comparable with aflibercept.
Right. Okay.